Hello, and welcome to today's webinar, Report Back from SGO, What's the Latest in Cervical Cancer? I'm Aisha McClellan, the Cervical Cancer Program Coordinator at SHARE. Today's webinar will focus on any new information and research advances from the Society of Gynecologic Oncology annual meeting in March. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecologic cancer and provides outreach to the general public about signs and symptoms because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and helplines, please visit our website at sharecancersupport.org. All participants will be muted during the presentation. Once Dr. Ko finishes presenting, we'll begin the Q&A session. Feel free to ask any questions through the Q&A section at the bottom of your screen. Remember that Dr. Ko is unable to give specific medical advice, so please keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting the subtitle option. This webinar is being recorded and will be available on the SHARE website soon. We are very excited to have Dr. Ko joining us today as our speaker, and now I'd like to hand it over to Dr. Ko to introduce herself.
Wonderful. Thank you so much for that wonderful introduction. And I will just give a very brief intro about myself. So I am a gynecologic oncologist, associate professor at the University of Pennsylvania here in Philadelphia. I have the privilege to take care of patients with gynecologic cancer, as well as patients with complex gynecologic conditions. And additionally, I am a physician researcher with an emphasis on health services research. And primarily that means thinking about how we are able to provide care to our gynecologic cancer patients. How do we ensure that we have policies that really fulfill the best delivery of care and access to care to everyone that has GYN cancer? And by bridging my daily work with, a lot of data science as well as research and thinking about how we can actually enact policies to ensure that everyone gets the care they need. So thank you so much for the opportunity to speak today. And without further ado, I will bring up my slides. And let me just make sure we have the set of slides here. And I'm going to make it full screen. Wonderful. So thank you again for the opportunity to report back from SGO 2024, our annual meeting in March. What's the latest in cervical cancer? And here are my disclosures. So for today's talk, I'd like to present an overview of a cervical cancer update. First, talk briefly about cervical cancer. What is it? And also the epidemiology, how common is it? And then what are our efforts for eradication of cervical cancer? Talk some about updated staging, and most importantly, talk about treatment for cervical cancer. Where are we at? So cervical cancer, let's define the disease. Cervical cancer develops from the cervix, which is basically the bottom portion of the uterus, as you can see here on the diagram. And the most common type of cervical cancer is squamous cell carcinoma, followed by adenocarcinoma. There are other types as well, such as neuroendocrine, clear cell, and others that are certainly less common. Now, cervical cancer is the fourth most common cancer in women in the world. It is generally caused by persistent infection with the human papillomavirus called HPV. And we do know that prophylactic vaccination, meaning preventive vaccination, and screening tests are effective to prevent precancer conditions as well as cervical cancer itself. And when we talk about precancer conditions, that's frequently referred to as dysplasia or pre-malignant. So as stated, cervical cancer is largely driven by the human papillomavirus called HPV. And in fact, HPV causes about 95% of all cervical cancers. As you can see in this table on the left, HPV virus is also associated with other cancers of the body in women, including anal cancer, vulvar cancer, and vaginal cancer. But these are far fewer compared to cervical cancer. And of course, HPV is associated with cancers in men as well as listed. And it does usually take some years of HPV effect on the cervical area before it becomes truly cancer. So that's why there are screening tests to be able to catch these changes before it develops into cervical cancer, as you can see in the bottom diagram. So how do we actually do these screening tests? Traditionally, we have things called the pap smear, as people refer to it, as well as HPV testing. So what this involves is a pelvic exam done by a physician or a healthcare provider to actually look at the area, the vagina, the cervix, usually in an office setting. And also there's a component of a manual exam where you're actually palpating with your hand to see what the cervix, vagina, pelvic organs feel like. So people usually refer to the PAP test as a PAP test, otherwise known as a Papa-Nicolau test, or now cervical cytology test. These words are all used interchangeably. Basically, it refers to obtaining a sample of the free cells off the surface of the cervix using a broom or a spatula with a cyto brush. And you can see in the diagram here how that's done. Additionally, there's the HPV test, which is collected at the same time frequently as the PAP test itself. And again, you're using the same broom or brush or spatula to do this, and it's basically run off the same sample that's being collected by your healthcare provider. Now, if the PAP test and HPV test comes back positive or concerning for abnormal condition, usually it leads to doing a colposcopy and biopsies in the office as the next step. So as you can see here, this is again performed in the clinic setting. It does not require any special anesthesia. It generally is quite tolerable, could have a little bit of discomfort, but is very tolerable. It involves looking at the cervix directly with a magnifier, like you can see here, and then doing directed or random sampling biopsies where you're taking tiny piece of tissue and examining under the microscope to see what is really going on there, if it is precancer or possibly cancer. Additionally, if there is a diagnosis of cancer based on that colposcopy biopsy, additional tests are usually done in order to identify whether the area involved is limited to the cervix or possibly beyond the cervix. And so there are different type of imaging studies that we use, such as pelvic ultrasounds that give a general idea of if there's something abnormal in the uterus, cervix, ovarian areas. But more specifically, we have, for example, MRI pelvis, which can provide details of the cervical architecture, especially if there's a tumor present in that area, as well as if there's any metastatic lesions, meaning tumor elsewhere. There are also things such as CT scans that, again, can provide details regarding metastatic lesions, especially in the chest, abdomen, pelvis, and it's very fine-tuned for that. And lastly, PET scans also can provide details regarding areas of disease in the cervix as well as beyond the cervix throughout the body, and can actually provide details regarding activity of these lesions. And generally, your healthcare provider can help decide which test might be best given your specific condition. So again, how common is it? How common is cervical cancer? In the US, approximately 13,800 new cases of invasive cervical cancer will be diagnosed in 2024, and about 4,300 women will die from the disease in the year. And overall, the lifetime risk of cervical cancer is about 0.7%. And you'll see in the graph here on the right that most women are diagnosed with localized disease, meaning the cancer is just pretty much in the cervix itself. And that's actually a good thing that these cases are caught before it's widely spread. Now, we do know cervical cancer incidence and mortality in the US has improved over time. You can basically see on the top line that the number of cases of cervical cancer each year are actually dropping, and the number of deaths are actually dropping as well based on the bottom green line. And you can see that over the time, HPV vaccine instituted in 2006, followed by co-testing of PAPS plus HPV testing in 2012, as well as HPV alone testing instituted in 2018, I think have certainly played a large role in seeing the decrease in cervical cancer. However, cervical cancer is still present. It's certainly not eradicated. And in fact, it's actually affecting some populations more than others, even in the US. And what we've seen is that certain populations by race, for example, the Hispanic population, the Black population, and even also the Native American population are certainly affected more by cervical cancer than, for example, the white population. And you can see the brown squares reflect the Black, the blue triangles reflect the Hispanic population, the green triangles reflect the Native American, and they're just, those lines are higher up, meaning there are more cases each year diagnosed with cervical cancer in those populations than the white. Ultimately, I think we are all trying to eradicate cervical cancer as an ultimate goal. And here, just again, reflecting the difference in populations, we can see here that Black population have a higher incidence, meaning there are more cases of cervical cancer that affect that group. And then there's also actually the highest death rate in that group as well. But certainly it is affecting the Native American, the Hispanic, as you can see in the bottom bars as well. So where are we now? And how is this being seen across the country? This was a study presented by Dr. Castellano et al. At our annual meeting. And what they did is they looked at several data sources, including insurance data sources, as well as the US Census, as well as treatment data sources with the American Brachytherapy Society, to see where are the cancer cases happening and what are the social factors behind it. And so you can see here from the map that they presented that this is a map of the US and that there are cervical cancer cases across the US that are occurring. Those that go to the purple and almost dark purple areas are where the burden is the highest. So CC reflects cervical cancer burden. You can see what states are affected the most. Some in the more southern states, across from the west to the east. And then you can also see where there are treatment centers, for example, brachytherapy, radiation treatment centers that are available. And of course, there are some disparities where there are lots of, dark purple areas that don't necessarily have treatment centers really nearby them. What we can see is that the social ramifications, that poverty level on screening and disease is associated. So again, Dr. Castellano demonstrated that a higher percentage of low-income households in region correlated with less screening for cervical cancer and actually a higher burden of cervical cancer as well. So we realize that, yes, more screening is needed. There are areas in the country, especially socially economic, maybe lower resourced areas that really could benefit from more resources, more testing, more treatment options for these patients. And what we can see is that when you do have treatment services available, meaning radiation brachytherapy centers available, that in fact there appears to be less burden of cervical cancer cases that are metastatic. So again, having the resources in the places where we have the most cancer cases actually has a better outcome. So what are all the efforts to eradicate cervical cancer? We've now talked about the burden of disease and how it impacts populations across the US. What are our efforts to eradicate it? So there is an international effort really based emphasizing this. The World Health Organization has initiated a cervical cancer elimination campaign back in August 2020. And they're hoping by 2030 that we can achieve these goals. Number one, vaccination. 90% of girls are fully vaccinated with the HPV vaccine by the age of 15. Screening, that 70% of women screen using a high performance test by the age of 35, and again by the age of 45. And treatment, that 90% of women with precancer are treated, and that 90% of women with invasive cancer are managed. And this is a worldwide goal. So what are we doing in the US? The Society of Gynecologic Oncology has a cervical cancer task force that is led by Dr. Mark Einstein, Dr. Deanna Teo, and this group is dedicated to reviewing, providing guidance regarding vaccination, screening, management of cervical cancer, and partnering with the goals of the WHO, which we just mentioned, to achieve these goals to eradicate cervical cancer. We want to collaborate and advocate with other medical organizations and really expand the global training program with a focus on surgical management to be able to provide treatment to women with cervical cancer throughout the world. And so here there's an opportunity to participate, including patients and patient advocates. We are hoping to amplify the voice about cervical cancer knowledge, information, and treatment opportunities. And here's a contact if you are so interested in joining the effort, jessica.oldham@sgo.org. Also, Foundation for Women's Cancer, again, is dedicated to providing cancer awareness and treatment to gynecologic patients throughout the whole country. In the US, September is actually Gynecologic Cancer Awareness Month and is a great opportunity to really amplify the information about cervical cancer as well as all GYN cancers. Again, if you're interested, feel free to check out this webpage, Foundation for Women's Cancer. And research and funding is critically important because that is how we actually identify new drugs and bring new treatments and better treatments to cervical cancer patients. Here, I wanted to just share with you all what is our sort of funding environment dedicated to different cancers in the country through the NIH, National Institutes of Health here at the US. And you can see that cervical cancer has had some funding available, 57 million back in 2015, up to 73 million in 2021. And that is good. But we are always looking for more support to be able to make more discoveries and have more treatments for our patients with cervical cancer. You can see relative to other cancers where cervical cancer stands. Endometrial uterine cancer is actually the most common GYN cancer, but only funded at 14 million. Ovary cancer is, of course, a concern as well, 134. But compared to breast and prostate cancer, breast cancer gets substantially more funding, as we can see here, at 558 million. So, we're always thinking about how we can think about resources to actually investigate cervical cancer research. And here we're going to dive deep into cervical cancer screening, prevention, and then treatment. So we realize that there are gaps, challenges, opportunities in cervical cancer prevention, screening, and treatment. This was presented by Dr. Castle at our annual meeting, and we realized that there are barriers, right? Barriers including clinical centers, testing costs, and available follow-up. There's certainly social barriers to accessing healthcare, like transportation, time. There's barriers to having available pathology services and lack of equipment, and even barriers to vaccination knowledge, trust, society barriers and others. So what are some of the initiatives to try to overcome some of these barriers? One of the highlights here by Dr. Castle is bringing about HPV testing of self-collected specimens. So not requiring a healthcare provider physician to actually do the collection, but doing it yourself. And what we realize is there are a lot of studies out there and more data that suggests that self-collected specimens may be as good at picking up HPV positive cases and being able to then, triage patients to appropriate healthcare provider to get the next step, sort of the colposcopy, biopsy, and physical exam evaluation that we've been talking about. And by using this approach, that it actually is pretty good, that it could decrease the burden, it can get out into the community more, and that it's actually pretty good at identifying these precancer changes of the cervix, and therefore being able to prevent, it becoming cancer, actually being able to pick up these cases before it gets to that point. And with the self-collection technique, they found that based on the studies available, it's highly acceptable to the patients. It doesn't require a traditional pelvic exam, which can be more uncomfortable. And one of the concerns that women might have is that they feel like they might not be able to do as good a self-collection as the provider, but in fact, there's more and more data that says maybe it is okay and as good. So in the US, there is a big initiative by the NCI National Cancer Institute called the Last Mile Initiative, and they've named it the SHIP Trial Network, or Self-Collection for HPV Testing Improve Cervical Cancer Prevention. So the SHIP trial, it is conducted at multiple medical cancer centers across the US, but the point is that it's actually testing this self-collection process and ultimately trying to demonstrate that is acceptable, feasible, accurate, and able to pick up cervical cancer and cervical precancer conditions for patients across the country. So that's very exciting. And when we think about the WHO, again, they also have guidelines that they've put out, being the following. They recommend using HPV DNA detection as a primary screening test rather than visual examination or cytology, the traditional pap smear as we know it, in screening and treatment approaches among general population of women just in general, as well as those living with HIV. And the WHO suggests that using this HPV DNA primary screening test with triage or without triage is to prevent cervical cancer among the general population of women is the way to go. They do say that when providing HPV DNA testing, they suggest either using samples taken by a healthcare provider or self-collected among the general population of women, and women living with HIV is appropriate. And they suggest that regular screening interval every 5 to 10 years when using HPV DNA detection as the primary screening test among the general population of women is appropriate. They also say that screen and treat approach using HPV DNA detection as a primary screening test, and suggesting treating women who test positive for the HPV DNA is appropriate. In the screen, triage, and treat approach using HPV DNA detection as a primary screening test among the general population, that additionally using partial genotyping, colposcopy, visually examining, or cytology to triage women after a positive HPV DNA test is appropriate and should be done. And where HPV DNA testing is not yet available or operational, then the traditional screening interval of cytology or visual examination every 3 years is also appropriate. Now, in addition to all the screening tests we talked about, HPV vaccination is also important. And we do know that the HPV vaccine protects against infection from 9 HPV subtypes, including the 7 types that cause most HPV-related cancers as listed, as well as the 2 low-risk types that cause most genital warts. And in fact, the vaccine is estimated to prevent up to 90% of cancers caused by HPV infection and genital warts. It offers the most protection when given to boys and girls aged 9 to 12, and it is approved for for adults in the US age up to 45 years, including both men and women. And so the HPV vaccine in general is a total of 3 injections, the first, then 2 months, 6 months later. However, actually in kids, they state that just 2 injections are sufficient, given about 6 months apart, are sufficient to give the same protection against HPV virus. And what we realize, though, even though the vaccine exists, it's still not widely used. And this is in the US as well as worldwide. And this was presented by Dr. Castle as well in the annual meeting, that you can see here, the green reflects the worldwide population, female population. And then there's demonstrating here, the blue is what of those are targeted by actual HPV vaccine programs. And then in the pink are the population that actually estimated population that actually got the vaccine. So you can see worldwide that there's a lot more opportunity to try to get the vaccine out to the population that really could benefit from it. And you can see that a high income population tend to get more vaccinated. And as we go towards the lower middle incomes, there's certainly less folks that are actually getting it. And this is another study presented by Dr. Wong at our annual meeting. And this is looking just at the US data. So what they did is they took, in the US, this All of Us database and rates of vaccination uptake by adults age 18 to 27. And what they found, there's lower HPV vaccination rates in older mid-adults who are unemployed, uninsured, and obese. That the burden of healthcare costs had negative impact on HPV vaccination rates. And that there, with the American Cancer Society US report, there was a 65% decline in disease incidence in women aged 20 to 24, while there's a 2% increase in incidence found in women aged 30 to 44. So that's just telling us that there is opportunity to get more vaccination out there, that we are not covering all the populations that would benefit from it. And that if we were able to do this, that we can decrease the burden of cervical cancer. So let's talk more now, diving into cervical cancer staging as well as treatment. So cervical cancer is generally when you're diagnosed. Following that, there's a assigned stage. And what that refers to as a sort of prognosis, what stage that you're given. If it's localized stage 1, generally has the best outcome, meaning the cervical cancer is only in the cervix area. If it's spread beyond the cervix to the vagina, it becomes stage 2. If it spreads beyond that into the other pelvic areas, stage 3. If it spreads beyond that, it becomes stage 4. And we can use both physical exam as well as imaging studies, as well as pathology information to define the stage. And so here in 2018, we have updated staging guidelines. As you can see here, it is very detailed, and it basically tells you by what the size of the tumor is and where it's located, along with adding in radiology information and biopsy information, what ultimately your stage may be. And that is important for several reasons, not only to tell what the prognosis might be for a particular patient, but also when we're thinking about research studies and who gets enrolled into different clinical trials. The stage is actually part of the eligibility criteria for studying different populations of patients with cervical cancer. So diving into treatment of cervical cancer here. Broadly speaking, cervical cancer is, or traditionally has been treated with surgery, followed by sometimes chemotherapy and radiation therapy after that. Now, that usually is limited to cervical cancer where the size of the tumor is less than 4 centimeters. Now, if the tumor is bigger than 4 centimeters, or the healthcare provider feels like it is not really a case that surgery is going to be the best option, then the alternative is actually to start with chemotherapy combined with radiation therapy. And that's what you're seeing in this second blue arrow line. So it'd be just going with chemo and radiation followed by surveillance, which is basically monitoring the disease after that treatment. Now, there are some more novel approaches that are being studied and have been studied, and that what you're seeing with the bottom line here, if the cancer is spread beyond the cervix, there's the thought to use neoadjuvant chemotherapy, for example. That refers to getting some chemotherapy before actually getting any surgery like a hysterectomy, and then possibly following by adjuvant. So I'll walk you through some of the different clinical trials that are now looking at some of these more novel approaches, as you can see, either doing chemoradiation with additional medications at the same time, or using this neoadjuvant chemotherapy approach and then into surgery. So here we're going to dive into the granular details of some of the presentations at SGO. This study was evaluation of efficacy and fertility after non-radical surgical therapy, extrafascial hysterectomy, or cone biopsy with pelvic lymphadenectomy for stage 1A1 and 1A2 to 1B1 cases. It was presented by Dr. Covens and his group. This is also called GOG 278. So it's a prospective study where they were enrolling patients with overall small tumors. So stage 1A1 and 1A2 to 1B1, so less than 2 centimeters. And basically, the idea is that if we do less aggressive surgery, less radical surgery, it may be just as sufficient with better outcomes for patients. And so the patients had either simple hysterectomy or just a cone biopsy with a lymph node dissection, taking out lymph nodes. And what they found ultimately, after enrolling over 200 patients, that the patients actually did pretty well. They had minimal toxicities, and that this approach, doing less radical surgery for early stage cervical cancer, appears to be safe with low complication rate. And so this is just, where are we going? We're trying to do less aggressive surgeries, hopefully demonstrating that the patients have better outcomes, less complications, and would do well in the long term. Another study in the surgical space presented at the annual meeting was this one: survival of patients with early stage cervical cancer after sentinel lymph node biopsy without systematic pelvic lymphadenectomy. This is also nicknamed the CENTIX trial and was presented by Dr. Sabila et al. And what this was an international study enrolling patients over 47 sites in 18 countries. And what they're doing here is for women who are undergoing hysterectomy for their cervix cancer, at the same time, they're getting some lymph nodes removed. And historically, a lot more lymph nodes would be taken out, called a pelvic lymph node dissection. But now we're trying to do less aggressive surgery, again, by just selectively taking out lymph nodes by injecting a dye into the cervix at the beginning of the procedure, seeing where the dye travels, and the lymph nodes that light up, either green or blue, depending what dye you're using, those are the lymph nodes you want to take out. And those are actually the very high yield for determining if there's any spread of disease. And ultimately, you may only take out 2 to 3, 4, 5 lymph nodes rather than 10 or 20, and finding that they're actually pretty good outcomes. So what they found was that when they looked at women undergoing this type of procedure, recurrence rate was actually only 6%. And this was comparable to older historical data when they took out a lot of lymph nodes, that the recurrence rate was about the same. And that the survival of patients doing this approach was excellent and comparable to those who had undergone the full lymph node dissection. So again, novel kind of surgical therapies for women with cervical cancer. Now, turning gear a little bit to talk about medications when we think about immunotherapy, chemotherapy, systemic therapy, and what are the advances in this space. So this is where we talk about precision medicine. And what is precision medicine? So the NIH has some information about precision medicine. Ultimately, it's where we're not just doing a one-size-fits-all approach. We're actually looking at the different type of, cervical cancers, tumors, et cetera, and getting down to the genes, the molecular biology, and being able to then target these cancers in a very much more specified manner. So what we know, this is a little background, is that cervical cancer cases had been profiled through the Cancer Genome Atlas Research Network. And this was taking a large number of cases, several hundred cases of cervical cancer, and looking at literally the gene profile, all these cases. And this was published in 2017. And with that information, it allowed us to identify that cervical cancer may be particularly sensitive to various type of medications, specifically, for example, immunotherapy. And we're going to dive into that in the next few slides. So, for example, presented at the SGO annual meeting, neoadjuvant tislelizumab plus chemotherapy in patients with locally advanced cervical cancer, prospective single-arm phase 2 trial. This was presented by Dr. Wenxin Liu and her group. And here, the approach was doing neoadjuvant chemotherapy before surgery. So as we mentioned earlier, one idea is actually do some chemo before a hysterectomy. And this was a study done in China, a phase 2 single-arm study, enrolled 26 patients with stage 1B3 to A2. They were given the tislelizumab along with paclitaxel, which is a traditional agent we use for many decades, plus cisplatin, again, another traditional agent used for many decades, or carboplatin. They take it every 3 weeks for 3 treatments, and then they go for surgery. And what they found is that these patients overall did quite well. Overall, 87% responded, 65% had a complete response, meaning that basically the cancer was fully treated. And looking at under the microscope, pathology complete response, 60% means that the tumor cells went away. That's actually quite impressive to see. We always think about side effects. 30% of patients had some type of side effect. And of course, those would need to be managed. So that's some novel data, and there's going to be more in that space. Another trial that was presented is a randomized phase 3 trial of induction chemotherapy followed by chemoradiation compared with chemoradiation alone in locally advanced cervical cancer. And this was presented at the annual meeting by Dr. Letterman and his group. So the idea here is that we are giving some chemotherapy before getting primary radiation chemotherapy. So this is called induction chemotherapy, and with paclitaxel and carboplatin, and then followed by chemoradiation for locally advanced patients with stage 1B1, 1B2, 2, 3B, and 4A cervical cancer. You'll see the criteria here for eligibility. The timing is strict, meaning when you get this induction chemotherapy, you have to finish that all in 6 weeks, and then you have to start that primary radiation chemotherapy 1 week later. So it's right away, and then you have to complete the entire radiation course within 50 days. So this is the protocol that was applied. They enrolled over 500 patients worldwide. Most 70% of those patients were stage 2B. And what they found was in the arm that got this induction chemotherapy, there was a little bit more side effects with low white blood cell count called neutropenia and fatigue. But overall, the outcomes were pretty good. And what they found was that ultimately highlighted in yellow, that induction chemotherapy should be considered standard of care in these cases, and that is feasible across the world. What they're demonstrating, there's improvement in progression-free survival as well as overall survival that was statistically meaningfully significant. This here is the algorithm with how they enrolled the patients. So you see you either go in the red group, which is getting the chemo before the primary radiation chemo, or you go in the blue group, which is the standard chemo radiation. And then they followed everyone up, and you'll see their survival curves here, which showed a statistical improvement in progression-free survival. The red line with the induction chemo did better than the traditional, and that's shown with the progression-free survival graph on the upper left, as well as the overall survival with a median follow-up of over 64 months, which is quite a long time. And for that reason, it is recommended to consider this approach now. And subgroup analyses as well, you can see here that many of the groups benefited from this new approach of induction chemotherapy. So this trial called the Interlace trial is definitely something we are all considering and thinking about applying to our patients. Turning to a different trial here. This is called pembrolizumab plus chemoradiotherapy for high-risk locally advanced cervical cancer, a randomized double-blind phase 3 trial, also nicknamed the A18 study, and it was presented by Dr. Linda Duska and her group at the annual meeting. So what this is a concept of using a new agent, an immunotherapy agent called pembrolizumab, and using it first line for patients undergoing primary chemoradiation. So this trial enrolled over 1,000 patients in 30 countries. And what they ultimately demonstrated is when you add this immunotherapy drug called pembrolizumab to the traditional primary chemoradiation, that there is also improved progression-free survival. And this was really significant. Interestingly, it did not improve overall survival in the entire population. However, when they looked specifically at patients with stage 3 or 4A disease, they saw improved overall survival. So in this subset of patients, it was particularly beneficial. And ultimately, the adverse events or side effects were similar between the group that got the immunotherapy drug versus the traditional group. Patient-reported outcomes were similar as well. And so basically, this data supports the use of pembrolizumab with chemoradiotherapy as a new standard of care for newly diagnosed, previously untreated, high-risk locally advanced cervical cancer patients. And in fact, highlighted in yellow, FDA-approved use of this drug in January of 2024. So here, again, you can see how the trial was designed. There are two groups, which we talked about, the new drug versus a traditional. With the pembrolizumab group, you had to continue taking that pembrolizumab for 15 cycles every 6 weeks. So it is for a long time. But that being said, the benefit is seen here with the progression-free survival. The green curve on top with a novel agent certainly did better with less recurrence and less death. And again, the overall survival, while not statistically significant, was beneficial for stage 3 and 4. And here, patient-reported outcomes are basically asking patients on trial about their symptoms, their quality of life, and so on and so forth. And basically, you can see it summarized in the table that the two groups were about equal. So even getting the additional immunotherapy, they felt, just as well as the group that got the traditional. So that's reassuring. Here, I wanted to share another study that was highlighted at our annual meeting. And this study is called the Primary Results from BEAT-CC, a randomized phase 3 trial of first-line atezolizumab combined with bevacizumab in a platinum doublet for metastatic persistent recurrent cervical cancer. This was presented by Dr. Oknen and her group. And so this we nickname it the BEAT-CC trial. What they were studying is adding atezolizumab, which is also an immunotherapy agent, to bevacizumab, which is an anti-VEGF agent. And this is a drug that sort of works by inhibiting blood vessel growth in the tumor environment. So when you combine these two drugs plus the traditional chemotherapy that we talked about, paclitaxel, carboplatin, it improved progression-free survival and overall survival in patients with recurrent or metastatic cervical cancer. And you can see the progression-free survival was improved with the median of 13 versus 10 months. And the overall survival was improved as well with a median of 32 versus 22 months. And overall safety profile was very manageable. So the takeaway here is that this new immunotherapy drug atezolizumab combined with bevacizumab added to platinum-based chemotherapy should be considered as a new first-line therapy option for metastatic persistent or recurrent cervical cancer. And this here is a diagram, again, showing this particular trial, the patients who were eligible for the trial, metastatic persistent recurrent cervical cancer, no prior systemic therapy previously for metastatic or recurrent, and they were randomized to these two groups, getting either the novel agents with atezolizumab with Bev versus only Bev and paclitaxel or carboplatin. And of course, the patients were assessed for recurrence, progression, and survival. And here you can see the curves demonstrating the benefit of adding these novel agents. The blue curve on top is the atezolizumab plus bevacizumab plus chemo versus the more traditional just bevacizumab plus chemo. And you can see the difference in improved survival with progression-free on the left chart, and then with overall survival on the right chart. Talking about another trial that showed certainly advances in cervical cancer treatment for recurrent metastatic patients. This is the efficacy and safety of tisotumab vedotin versus investigators' choice of chemotherapy in the second line or third line recurrent or metastatic cervical cancer. It also has some nicknames, ANOVA trial or GOG 3057. And this is additional data from the global randomized open label phase 3 study. This was presented by Dr. Brian Slomovitz and his group. And tisotumab was evaluated in patients with recurrent metastatic cervical cancer who previously received up to 2 prior lines of therapy, which could include receiving previously bevacizumab and or pembrolizumab, the immunotherapy agent. So tisotumab alone was compared to standard chemotherapy. They enrolled 500 patients, so it was a very large study. And they did show that tisotumab improved overall survival at the planned interim analysis at 12 months. There are some side effects, including eye, side effects on the eye, as well as neuropathy, numbness in the fingers or toes, and some bleeding, but none of them were serious or life-threatening. So the takeaway is that tisotumab is effective in second and third line setting with a median overall survival of approximately 12 months and may be considered a potential new standard of care. And so with this data, the FDA under accelerated approval program has this agent approved under the accelerated approval program and is currently under full review by the FDA as of May of 2024, which is very exciting. So what is this agent? So tisotumab is an antibody conjugate that targets tissue factor, which is found on cervical cancer cells. And this tissue factor is attached to a cytotoxic agent called MMAE, which basically gets into the cancer cell and basically disrupts their growth and basically allows the cancer cell to be killed. So this is a very novel approach to delivering cancer treatment straight to the cancer cells themselves. And so this here, you can see the way the trial was designed. It's for women with recurrent or metastatic cervical cancer, meaning they previously already generally received treatment, but now, unfortunately, the cancer has progressed and they need a newer treatment. And so using this drug versus chemotherapy, they showed that there was an improved survival. And so here are the survival curves. Again, you can see that overall survival is the curve on the left side, using this new drug versus traditional agents, and that there was definitely improvement at 12 months, 48% versus 35, and then progression-free, meaning did folks progress or pass. Again, looking at this right graph here with the new drug, 30% versus 18% at 6 months. So again, statistically improved. And you can see here, there are side effects, so we have to be very cautious and manage those, but with appropriate management that we can safely get the patient through treatment. Up to 50% do have some type of ocular event, 35% do have some type of neuropathy, but again, generally speaking, these can be safely managed. A couple other trials wanted to speak of briefly here, presented at the annual meeting: efficacy and safety of 9MW2821, which is an antibody drug conjugate targeting Nectin-4, monotherapy drug in patients with recurrent or metastatic cervical cancer. Multi-center open label phase 1/2 study presented at the annual meeting by Dr. Yang and their group. And this is, again, another novel therapy, again, ADC. So it's linking like a drug that can get into the cancer cell itself. And specifically for patients who have locally advanced or metastatic cervical cancer. This is still quite early phase. They enrolled 40 patients with a median follow-up of about 5 to 6 months. Overall response rate was 40%. Disease control rate was 89%. Again, still very early in the study, but it was overall well tolerated. So to say there are more and more agents out there that are being investigated that can get straight into the cancer cells themselves to hopefully attack those and be able to really treat patients hopefully with less other side effects and complications. And here I wanted to highlight another study that received a lot of attention at the annual meeting: efficacy and safety of trastuzumab deruxtecan in patients with HER2-expressing solid tumors, biomarker and subgroup analysis from a cervical, endometrial, and ovarian cancer cohorts. And this study is nicknamed Destiny, and it was presented by Dr. Vicky Macher and her group. Phase 2 open label multi-center study targeting tumors that express this HER2 protein. And patients either had 2 or more prior lines of therapy. They enrolled 40 cervical cancer patients. And what was truly impressive was the response rate that I will show you in the next few slides. The takeaway is that this new drug, TDXD, is a potential treatment for cervical cancer patients who were heavily pretreated with other medications or even radiation previously, and whose tumor expresses this HER2 protein marker, and there was a pretty impressive response rates. So again, this particular drug was studied in multiple cancer populations, including uterine, cervix, ovary, and you can see the response rates here. They treated 40 patients. You can see in the blue table, which is directed to cervix patients. 20 out of 40 had a response, which is quite good. And for those who really expressed the HER2 a lot on their tumor tissue, 6 out of 8, meaning 75% of patients had a response, which is actually very high when we're looking at patients who have been treated previously with other agents. So that is very certainly exciting news, even though the sample size was small. So, as we look at how far we come over the years, this summary slide from Dr. Terrari's presentation at the annual meeting demonstrates that we have certainly seen better agents, newer agents, and more improved survival for all our cervical cancer patients. Some of the older trials are listed here, looking at cisplatin, paclitaxel, then bevacizumab. Then we have this Keynote 826 with bevacizumab, pembrolizumab, and you can see that the survival has much improved, 24 months, 32 months, et cetera. And that is very exciting news for first-line recurrent metastatic patients. And then patients that need additional treatment after that, we have that tisotumab vedotin, which we talked about, as well as other agents such as cemiplimab. that are available. So these are all more novel agents, more targeted, and it really is opportunity for our patients. Here to summarize, this is a table from the National Comprehensive Cancer Network guidelines, all the agents that we can use now for treating cervical cancer patients. And these are basically all IV agents that are listed on this table. It's a little bit complicated table, but it's to demonstrate that we are looking at more and more agents now currently than we have in the past. And I have maybe 1 minute left to quickly mention a vaccine therapy. We previously talked about preventive vaccines, and now there are more and more studies available looking at therapeutic vaccines, meaning trying to get rid of cancer and get rid of the precancer conditions when it exists. So this is not prevention. This is actually trying to treat the precancer cancer. This was presented by Dr. Levinson at the annual meeting, where there's a vaccine that's targeting specifically the HPV virus, the E6, E7 protein within the virus. And for what it's worth, they studied, it's an early phase study. They were studying patients with actually precancer, what we call dysplasia, patients with dysplasia. And they found that there was a 78% rate of clearance of HPV-16 in these patients with CIN 2 to 3, so precancer condition CIN 2 to 3, and some clearance of other high-risk HPV types as well. And this was actually quite interesting that when they looked at the microscopic biopsies at 6 months, that 7 out of 9 patients had improvement of their precancer condition. So it's to say that, you know, there is a lot of study out there about using HPV vaccines to try to get rid of the precancer or cancer state, and not just merely prevent it. So in summary, when we talk about cervical cancer, where are we at? It's still prevalent in the US and worldwide, and there definitely are racial disparities and social factors that we need to consider when we're thinking about resources and delivering care. That being said, there's also been plenty of advances in the space of how we treat cervical cancer in terms of both surgery as well as the medications that we use for it. And also, though I didn't talk about it, there are advances in radiation treatment as well. There are novel therapies in precision medicine that we're applying to cervical cancer patients, and we're going to continue studying this to hopefully have even more to offer. And vaccine therapies are also being studied and very exciting in that space. So I thank you for the opportunity to present this talk today, and I'm happy to take any questions. And I will stop sharing my screen. I think, Aisha, you might be on mute.
Oh, can you hear me now? Okay, perfect. All right, thank you so much for breaking down these findings from SGO. This was super informative, and we really appreciate it. We had several pre-submitted questions, a few things you already touched on, but we'll just kind of get through them. And if you all still want to submit any questions, feel free. We'll try to get through what we can. Okay, so are there any new updates on immunotherapy specifically? I think now you're muted.
Sorry.
Okay.
So absolutely, there are definitely, as spoken of in the several studies I mentioned, the pembrolizumab. There's also cemiplimab. There's the other, immunotherapy agents that are being studied in China. But in the U.S., yes, pembrolizumab we've seen it's been FDA approved initially for advanced or recurrent, and now we're trying to move it up into frontline treatment, as was discussed. So I think it's really a huge benefit. It's a huge benefit, and I think patients are having better outcomes. So
Yes.
absolutely.
Awesome. I've heard more people are living longer with metastatic cervical cancer. Do you know what advances have made this possible?
Yeah. So I think it's multiple different types of advances. So in terms of the IV medications we talked about, immunotherapy is definitely one of them. In terms of the other, Tivdek, tisotumab vedotin, right? That's another very targeted therapy that's getting straight into the cancer cells. So generally not sort of affecting all the other cells of the body, but trying to get straight to the cancer cells. And there's, you know, even radiation therapy, there's more advanced radiation methods, right? In the old days, the radiation was not as refined. Now we're able to treat. Now, even if there's a little isolated recurrence, sometimes we can do a tiny bit more radiation, SBRT, refined radiation. So it really is a multi-combination approach, you
Mm-hmm.
know, to being able to really tailor therapy, offer it. And I didn't even mention this in this talk, but in addition, we are able to send tumor out for tumor testing, where we say we're going to genomic profile these tumors, right? So
Mm-hmm.
we're actually looking very broadly to see if there are any other gene markers, right?
Mm-hmm.
That there could be additional targeted agents that I
Right.
didn't even mention in this talk, but
Yeah,
that's what we're doing in practice. And so I think it really opens the door for opportunity to think about every type of modality of therapy and using combinations.
for sure, for sure. Um, have there been new developments in radiation for cervical cancer patients?
Yes, absolutely. And I think I briefly mentioned some of those newer techniques like SBRT, things like that, where it's really, and proton therapy is another form of very refined delivery of
Mm-hmm.
radiation. And so they're, of course, they're used for very specific situations and circumstances. So I
Right.
think the most important thing is that you would be able to talk with your healthcare team, you know, and if it were your gynecologic oncologist, your radiation, you know, oncologist or medical oncologist, and think about what at what point would be best for what condition of the cervical cancer journey, as I call it. But absolutely, and I know maybe some centers have some more of these advanced treatment options than others. I think it never hurts to just ask, you
Yeah.
know, even if your center didn't have it, you know, maybe are there other centers that may have it available? And sometimes these treatments aren't that long. So there may be an opportunity to say, you know, just for a particular portion of your treatment, you may be able to consider, is that an option for me? And the other thing I would say is good to ask about is, you know, sometimes you think, well, how would I get there? And are there resources to help me? And I
Mm-hmm.
think it's always good to ask your healthcare team and even organizations like Share, you know, maybe there are resources to help patients with travel costs or, you know, any of these other factors that are important to be able to get the care you need.
Absolutely. Absolutely. Um, let's see. Have hmm, how can patients keep up with the latest news and updates about cervical cancer treatments?
Yeah, great question. So there is so much news out there. Sometimes it's just hard to know where to look, right? So I think that there's certainly I mean, of course, asking your healthcare team, number one, right? That's always a good place to start. But then there are other sources that are certainly very, very informative, reliable. Of course, National Institutes of Health, National Cancer Institute. I think there are plenty of American Cancer Society. There are also foundation, and like we mentioned here, Foundation Women's Cancer, Society of Gynecologic Oncology has some resources. Patient advocacy groups such as Share also are trying to bring the information to the patients, right? The other things is, for example, even the annual meeting, which I spoke of, you know, the Society of Gynonc annual meeting, it is certainly open to patients. And there's actually also, you know, entire day conference that is dedicated to the patient, actually. So I
Mm-hmm.
think keeping your eyes out open for those are great opportunities, and you really get to get in there and learn and share experiences. And I think, and it's wonderful even as a provider, honestly, to hear the experiences of patients.
Absolutely. Absolutely. Last question. What are you most excited about for the future of cervical cancer treatment?
Yeah, I think I think there's just a lot of things that are exciting, you know, and I think that in the old days, you know, people were very cautious and reserved and hesitant about the treatments because there weren't as many treatments, right? We were more just saying, hey, there's standard radiation and there's maybe one or two or three, four drugs that we have available, right? But I think in the space that we're at now with precision medicine, like there's more options, there's more novel agents. And I think what we need to do is we just keep needing to move forward. Like we need to think about what are opportunities, how can we bring these novel agents literally from the lab studies to the patients, right? And ultimately, how can we have patients do better, have a better daily life, and live longer. We want to eradicate cervical cancer, right? Like that WHO has this huge initiative. It's not just one group or this group or that group. It's literally a worldwide initiative. And we
Absolutely.
can potentially prevent it as well, right? So it's I think I'm really excited that everyone's actually thinking about it and
Yeah.
that there are newer therapies, and we just want to keep building in this space, right? We really want more opportunities. So I think it's all of the above.
Awesome. Well, thank you so much, Dr. Ko, for an informative program, and thanks to all of you for participating and submitting questions. Please be sure to check out SHARE's upcoming educational programs and support groups and follow us on social media. Please take a moment to complete the survey at the end of the webinar. The survey will show up in your browser when the webinar ends, and the link will also be in a follow-up email. All surveys are anonymous. This concludes the webinar. Thank you.
Thank you.
Have a good day.